So this is how we've designed it. So we're first going to get to know our panelists representing all of these different areas of research. Ask your questions, ask things just about the research fields in general, ask about how conducive is it to fellow research projects, whatever you want. This is your time. This is the time for you. Then we'll go ahead and break for lunch at 12:40. And we'll all head outside to our tent that will protect us from the rain and the wind. And I'm sure once we all get in there, it will be nice and at least not so cold. And of course, during that time, feel free to continue networking with each other, with them. But then what we'll do is, because I think being outside for too long won't be super comfortable, we'll come back in. And many of you have already told us what your top 3 choices are. You can mill about to the different stations as you wish. They're all labeled. Carla's put up some signs. I think you all have the key that basically, in case the panelists don't know, clinical research will be, which we don't have the clinical research representative just yet, but that will be in the conference room. E160 is the conference room that's over by the side door. If you walk out and then to the right, it's over that way. Looks like we need one more chair as well. And for Raj, oh, there it is, sorry, okay. And then let's see, in the cafe, we're gonna have 2 groups there. So we'll have quality improvement and outcomes research. The cafe is where you pick up your lunches. So we'll have 2 sort of separate groups. This is all, of course, keeping in line with the modified yellow COVID status. Education and teaching will be over by the stairwell. That's again out to the right. You'll see there's some nice little comfortable benches there. So you can go congregate there. Basic science and then global health will each have their own little sections in the lobby, which is basically right outside the auditorium. And so what we ask is, let's just say, for example, clinical research is sort of the top requested and most popular one. It's in the conference room. If you go there and it's full, just go to the next one that you want to talk to and then go back again. So just kind of, if you could self-modulate, that would be perfect. And speaking of that most popular, I'll go ahead and text him to see if he is on his way, but I think we can easily get started with the others for now.
Do you want to make any closing remarks?
Oh yeah, good point, good point.
So after the breakout sessions, we can go until 2, and we won't reconvene here. So that'll be the end of first course. But we want to, Stacey and I both want to thank you so much for participating and coming today. Obviously, we thank all the participants and the speakers. Please be sure to do the evaluations. They still come in even in later days, so you can still go back to the emails from Mary Jane and get those done. If you also have overall comments about the course, ways to make it better, things that don't work for you, please put that in the general comments as well. And if you want to reach out to us individually, just shoot us an email, and we're happy to talk about the course. So thank you for coming. Okay, so just logistically wise, so we're gonna be in here to start. This first session is meant to be pretty brief, just kind of an intro to everybody that's here, kind of a sense of the different areas of pediatric research that are available in different fields. I'll open up for questions if there are any, and then we'll go to lunch, and then from there, the core of the sessions are the lunch and the breakout. So you get to meet with each person individually, talk about their areas of research and how to get involved in those areas. So we're still waiting for Dr. Raj Basu from critical care. He's representing clinical research. But what I thought I'd do is just, instead of introducing everybody, just have everyone go down the line. We can start with Jen, and then they can just briefly introduce yourself, the area that you're involved with, and then maybe just like an elevator pitch about what sparked your interest in your field. So how did you get into education, outcomes research, et cetera? So that maybe we'll start from there, and then we'll open up for questions.
You guys hear me on this? Okay. So I'm Jen Spicer. I'm actually an adult ID physician, but have worked a lot actually with Holly Gooding here. So I am involved in medical education research. I did some clinical and epi research actually during my fellowship and in med school. I've been here at Emory for all of my training and knew that I really loved education and teaching and wanted to make that my scholarly pathway. So I ended up going and getting a master's in health professions education, and I'm completing my degree right now, working on my thesis project, and have become really passionate just about how we improve not just teaching and kind of education, the way we think about it, but also things like admissions processes, leadership, recruitment, faculty retention. There's just a lot of wide areas within educational research to go into. And so, similar to many other types of research, there's opportunities to do kind of like quantitative type research, surveys, or other things like that. Also, qualitative research, which has become my passion. Interviewing people, finding out about their stories, and trying to figure out how to use that to improve the way that we do education. And so I think education's in general a pretty young field, research wise, and has changed a lot over the last decade. And so it's something that within Emory, there's a number of people now who have additional degrees and experiences doing educational research. And it is a great way to get scholarship. And so I'm happy to talk to anybody. I felt like I didn't have many people to talk to during my training, which is part of the reason I went to get a master's. But now there's a lot of people here with experience in it that I'm happy to connect you with. Anything?
Oh, that's
else?
great.
All right. Hi, everybody. I'm Holly Gooding. I'm the head of adolescent medicine here at Emory in the Department of Pediatrics. But I'm also internal medicine trained, like Jen, not med peds actually, so just internal medicine. And I think that probably does influence my focus on outcomes, because what are the outcomes of pediatrics other than healthy adults, or at least that's what we're hoping for. And I have another confession to make, other than not being a pediatrician, which is that I'm not entirely sure, Stacy, what you mean by outcomes research, other than I am the person, but I'll tell you what I think it is. And if I get it wrong, I would appreciate you amending. Awesome. All right. So Matt at the end is going to correct me, because when I think about the type of scholarly things that I do, I think they definitely all have outcomes, but they span the gamut from, I do a lot of medical education research, some with Jen, looking at outcomes of learning. I do some quality improvement projects, looking at outcomes of the care that we give and the processes, really, I guess I would say, of our care at our teen clinic at Hughes Spalding. I do epidemiologic research, which I think falls into outcomes research. So looking at large data sets and the outcomes of people in longitudinal cohorts. And right now I have a study trying to influence the health behaviors of young women to improve their cardiovascular health outcomes. So to me, outcomes sort of runs the gamut, but I think it often is things in the realm of quality of life or other disease states further down the road that are not necessarily being affected by like an interventional drug or clinical trial. So come talk to me if you want to talk about all those things. I think in some ways it's the broadest category because all of the things that you're curious about and hoping to affect are really outcomes.
Thank you. Hello, everyone. So I see a huge Hemong group here, and welcome all the fellows. I'm Shanmughnathan Chandrakas, and I go by Shan here. I currently direct the immune dysregulation immune defect transplant program. And many of you think, what do you do in immune dysregulation? So it goes back to how I started my research work. I did my initial training back in India. We had a great clinical exposure. Every patient you see one here, we saw 50 there. So, but what always intrigued me is the unknown, always intrigued me in trying to understand, be in a subspecialty that works in the gray zone, and also try to understand things that are not already described. So that got me to the interface of both hematology and immunology and also rheumatology. There are a lot of these patients lying in this gray zone, no one claims them. And trying to address that needed more research understanding of what's going on. So I always believe in destiny. Like I back in India, I used to correspond to people here, trying to understand what is going on. And one of the people I corresponded with at Cincinnati Children's, I used to regularly correspond there. It almost ended up with my fellowship there without even me realizing how that happened. So I think that's where if you strongly believe in something and you think this can lead you to a career that will be career defining, just don't lose hope. You just need to keep focusing on that. So in Cincinnati, as you know, first year is always going to be brutal. So I did residency back in India. It was brutal there, but I was not prepared for the fellowship being that brutal. So maybe I'm getting older, right? You're not getting any younger with time. So during the fellowship, one thing, the research year of my fellowship, I quickly realized is we are coming in at the peak of our clinical experience. Our residency program, you've gone through 3 years of clinical training, and fellowship, you're seeing a subspecialty patients. You're so used to seeing many instant gratification. You saw a patient, you diagnosed them, you treated them, you got, oh, this is great, he's feeling good. But research is more a long haul thing. Like for my first 6 months in research, I had no clue what I was doing. I knew I wanted to do this, but what takes me there was always a challenge. I had several questions along this way, kept questioning myself. I'm a reasonable good clinician. Do I really want to do this? And your peers, many times they're all supportive colleagues in the lab, but everyone is busy in their own thing. So sometimes it's very hard to come in without any background in basic research and start that going to a level to catch up with others, your postdoc in the lab or a graduate student in the lab to catch up to that level. It does take time. You need to be patient. But eventually, by the end of my second year in research, I got to a phase that I'm comfortable with what I'm doing. I can go back to my mentor and ask, this is not the right thing to do. I'm being doing it hands-on. I know this will work. So it takes time. So if you're seriously thinking about a lab research, it does give you an option to address questions that have not been addressed in the clinical realm of things, both translation and also basic tools with the murine model or translational tools that we have. It's an exciting time to be in this realm of things, but it takes time. So be patient. By my second year, I would say I was more comfortable with what I was doing. I could get back to my mentor saying, this hypothesis is not going to work. I'm not going to get a paper from this. I need to do this to be able to get to X, Y, and Z. Once we got that, then we have very good ownership of what project you're doing. Many a time lab research you don't get results in 2 months, 3 months, several experiments fail. So, but I was happy I did that because I did in a lab that did both stem cell biology. My co-mentor was the immunobiology person working on a disease model of HLH. So I had a very broad exposure there, setting up for the type of clinical program I want to lead later, and also there's a really good marriage between what I had interest in research and what I had in clinical. The next main career move is how do you transition from a faculty to from a fellow to faculty. That has always been a challenge for me. I got to move institutions. That means moving from Cincinnati Children's to here. So instead of giving up lab research, I still was able to convince people here, even though I'm not funded, I have the background to take this vision that I have to a more established lab. So I was lucky for the leadership to give me support here, but it took time. It's doable. And for a person like me who was 100% clinician trained in India to be able to establish a successful lab, have 4 people in the lab from a mentee to a mentor transition, all this have been extremely rewarding. And seeing your research can make a change in how these diseases are perceived and managed is the most gratifying thing. I'm not saying this is easy. Everything comes in with challenges, but of all the challenges you take up, this is one of the most gratifying things that you do. I've met with Stephanie and Robert yesterday. One of my mentors used to tell me, Shan, if you're into it, you're not into it for money. You're not into it for quality of life. You need to think of it as you're in an active duty, military duty. There's a pride and honor in what you do. If you have that, you will continue with it. It will excite you every day you do it. If you don't have that, there are 100 different opportunities for you. There's pharma, there's other things that you can have a great quality of life. So if you have that passion, I think this is a great field. This is exciting. multiomics, everything that is available makes the research even more exciting. So I can keep going. I'll pause here.
Hi, everybody. I'm Brittany Murray. I'm one of the pediatric emergency medicine attendings, so I know my fellows. The rest of you, I'm sure I will get to consult on very interesting patients at some time. I'm also the director of the Global Health Office of Pediatrics, and that's where the majority of my research lies. So I wouldn't actually most of the time describe myself as a researcher. I grew up in the middle of nowhere, northern Canada. It's where Canadians do rural rotations in medicine. So when I wanted to go into medicine, I thought initially I was going to go back there and practice and try to make things better. But I realized very quickly that I loved being in academic environments. I loved teaching residents, fellows, working with medical students, and that just doesn't exist where I'm from. So I struggled a long time in trying to figure out how would I work in an environment like this, but work to make places like where I'm from better. So with that, I first began doing work in lower resource settings within the United States that transferred patients to my pediatric emergency department at my big academic quaternary center. So all the places like the ones across Georgia that send patients to us. And we would do in situ simulation of providers in those places. And we had this great program going. But we realized very quickly that without being able to publish and describe that program so that others could replicate it, our work had limits. But if we could describe it, we could then tell others how to do it and make this bigger impact. So that was the first sort of foray into research that really clicked with what I wanted to do as a physician. And then near the end of my residency, because I was doing this work in the United States, my residency program started to have a partnership with a hospital in Tanzania. And they said, hey, you're teaching in places that have less resources. You love teaching. Would you be interested to come to Tanzania? And I was like, hey, I've never been to Africa. That'd be awesome. So I went for what I thought was going to be a month. And I've ended up doing research there for the last 13 years. And so I fell in love with Muhimbili National Hospital in Dar es Salaam, Tanzania. There was this great infrastructure set up where we worked with the National Hospital, which is where we were, the largest medical school in the country, which is Muhimbili, the medical school portion. We worked with the Ministry of Health and the African Federation for Emergency Medicine, and we defined emergency medicine as a specialty in the country and designed a training program, training materials that were culturally and contextually relevant to Tanzania. And so I loved teaching and loved doing that clinical work, but unless we were able to describe what we were doing in Tanzania, nobody else could replicate it. So the majority of my work has been doing that, has been describing educational programs that we set up in Tanzania and how we did that. And our basis from the African Federation of Emergency Medicine is now used in 22 countries across the African continent and other places like Haiti. I also wanted my residents and trainees in Tanzania to be able to answer questions that they had. So I run a course very much like this for my trainees in Tanzania to teach them how to answer their own questions, because the majority of medical literature comes from countries like America. So when we talk about a febrile seizure, that's sort of like a nothing event, right? If you have a febrile seizure in Tanzania, that's an event that needs workup. So we're trying to define what we're seeing in pediatric emergency care in Tanzania and trying to make sure that we get our information out there so others know best practices for that setting. In global health, there's a lot of other work that goes behind research because like the biostats core that met with you guys earlier today, that just doesn't exist in the hospital that I work at there. Managing grants, how to make sure that when you get a grant, the money actually goes towards your grant in your department and you know how to manage that. All of those processes are really tricky to set up. And so my current work and my current grant is actually having Emory faculty support faculty at Muhimbili National Hospital in running research and quality improvement projects. For those of you who are PICU fellows, our PICU is also doing a lot of clinical work with the PICU in Tanzania. But through all of that is how I got into research, and I really realized a couple things, that in order to amplify the work that I'm doing, I needed to be able to tell people about it, and that's what publications do. And then to get dollars and support, you need to be able to have sort of academic currency. And that academic currency is research, is being able to put it out there. And so even if you don't consider yourself someone who like really is going to be a full-time researcher, I encourage you to think about how it will affect your longer-term career goals. I also work with the residents and students here in the US to try to help them get into global health research and do that in sustainable, bidirectionally beneficial ways. And so if you're interested in working in lower resource settings within the US or places abroad, please come chat with me. I'm happy to talk about how we might be able to do that. Thanks.
Awesome. So I'm Parmeet Sachdev. I'm a hospitalist by clinical practice, but I spend a majority of my time doing global health research and administration. We have a new global health and equity office in the School of Medicine. So my journey to global health happened in medical school when some of my classmates came back from Jamaica on spring break and started having fevers and headaches, and then a girl had a seizure, was admitted and had eosinophilic meningitis, and the CDC was rushed in and was found to be angiostrongyllitis cantonesis, which had never been isolated in the Western Hemisphere until that. And I was like, I want to go to CDC. That's cool. So after I finished my training, I came to Atlanta to spend time at the CDC, and that's really where I learned how to do research. But research in a different way from a public health perspective, looking at populations more applied. We're talking about outcomes research. I'd say, well, what I do is very outcomes based too, and I think having that dedicated time of 2 years of focusing on public health research really gave me the tools. I did my MPH prior, but that was just theoretical. And then after that, I've been in faculty now since 2007. And I'd say three reasons why global health research is exciting. One is the problems it tackles. We're in the middle of a pandemic, right? I mean, that's one. The climate catastrophe. Really our world's biggest problems. Global health can tackle those. I think the second is opportunities for non-traditional funding. It's all about getting your funding for research, and what's great about global health is they're non-traditional avenues from foundations, from other government agencies other than the NIH, which I think really can kind of broaden your ability to gain funds. And I think the third is if you really like to see your research be put into action and make a change, global health is exciting for that. So direct action to policy. So some of our work has led to changes to global policy by the World Health Organization and other entities. So if you really want to get that practical end, not just your JAMA or your New England Journal publication, but something that's actually going to impact policy, global health is exciting. Thanks.
I'm Matt Lynham. I spoke yesterday. I'm one of the pediatric infectious disease doctors here. I'm the hospital epidemiologist for Scottish Rite Hospital and medical director for outcomes for the system. I first became interested in quality improvement back when I was in training. The hospital that I worked in was very, very, very devoted to quality and safety and improvements, and so I was kind of at the right place at the right time where quality improvement work was really taking off, and had the opportunity to get a lot of experience there. I actually stayed on after I finished my ID fellowship and did a quality improvement research fellowship for an additional year, and went through a couple different quality improvement training courses to get more skills in quality improvement. But really what got me interested in it was sort of through infectious diseases, sort of seeing all of the things that could be done better. Kids having, healthcare associated infections, device associated infections, and things like that, and wanting to make it better. And that's where, quality improvement became sort of a skill set, a set of tools to actually do that. And one of the things that I really enjoy about quality improvement is you can really get in working sort of in the system right at that moment and actually make things better. And for someone who has ADD, it's very nice to get that sort of immediate gratification of seeing some changes and putting things in place, and seeing that change actually happen right then and there. But from a research standpoint, I think there's a lot that we can do with quality improvements. A little bit of thoughtful design on the front end on how you design your improvement project can add sort of some validity to your methods and to your outcomes. And publishing quality improvement is very important because it helps all of us learn together. Interventions that work at one institution may be ideas for someone else to try to test and apply in their setting. As I talked about the other day, it's not necessarily generalizable, but it is important knowledge that can be taken and applied and help everybody get better. So that's quality improvement in a nutshell. Look forward to talking with more of y'all later.
All right, hey guys, I am sorry to be late. I'm partially delinquent because I misread the schedule, and also I was on the phone with Medtronic, ironically enough, trying to squeeze some last money out of them for a meeting I'm planning. So, my name is Raj Basu. I'm one of the intensivists, and I'm going to talk to you a little bit about clinical research. It's important that I start kind of not on a life story, but just to tell you that I am the son of biochemists, and I grew up trying to break the analytical balances in my parents' labs with my He-Man characters and other things. And I spent a long time cutting my teeth in basic science. When I first joined, I trained in Northwestern, and I got into a lab very quickly as a resident and as a fellow to do molecular biology and signal transduction research. So I'm well versed in the lab. And then when I went to Cincinnati as an early stage faculty, that's when I inherited the blood of mice on my hands. And so I've killed a lot of mice. And I got into this idea of I'm missing the connection. I'm missing the direct connection to the bedside. And all of you are clinicians. And I think clinical research, and everyone up here that I've worked with, and everybody at CHOA recognizes that vital connection to your training to marry two jobs. Other than your job of being a good human at home, you have two jobs. You have to be clinically functional, and you have this academic side. And the obligation on each of you is different based on your program. But clinical research itself probably is one of the most tangible, this makes sense to me. What can I do academically, and asking questions that has some clinical manifestation at the bedside. And during your training, one of the things I would emphasize to you is to make sure that you tackle the idea of doing research from a feasible perspective. Having the right metric of what timing is and what the longitudinal perspective is really important. Like, I have grand designs for my own academic work that will probably take the next lifetime of mine and the one after that to achieve. But on a week-to-week basis, I'm thinking about what are the deltas I can create. So clinical research is much different in some ways than some of the other forms of research, because Matt was talking about QI and the immediate, kind of, you can see your results, you can do rapid cycle improvement things and interventions. Clinical research is difficult because the boundary between your research life, if you're at a bench or if you have a home, and when you're doing clinical research, is hard to find. It's very difficult to design negative controls properly, positive controls. The output and what you think, I'm going to answer this question from a hem-onc perspective, from an ID perspective, seems very tempting and tantalizing, but it's really important in my mind to do clinical research before you collect any data. Like, you design your experiments, you design your question correctly. There are great opportunities in peds, more than adults even in some ways, to interface with people that you never thought you would interface with, meaning industry, other scientific partners. Like Emory and Georgia Tech are full of them. Engineers, philosophers, public health people. There are great opportunities to do collaboration. And I think clinical research relies, if you're looking to do this, I would really advise you to have a mentorship team and not just one person. So the mentorship team involves somebody who's a content mentor who can guide you if you have a project you're thinking about of that project itself, the details, like I am an expert in that field. And then you have a methodologic mentor. If you're going to have somebody who does population health, if you have somebody who does K-type cluster stuff, if you do mixed methods, it's important to have a methodologic person who's a bit unbiased with relation to the question you're asking, and then to have somebody who knows how to coordinate those things. And it's okay if they're not in your division. It's okay to spread those around because you get a broader perspective. But I will tell you, I'm biased for all of you not to do clinical research, but really to find a question that you're passionate about, to find a question that resonates with you, and give yourself the flexibility to know, I need some skills. This is your time to develop skills, because if you can represent those skills when you go looking for a job, that speaks more importantly than, oh, I did this project on signal transduction and TGF-beta, which didn't really work all that well for me. So I'm looking forward to talking to you guys in person. Sorry I was late.
Great. Oh, thanks. So I think we have a little bit of time if anyone has any questions for the panelists, and then we'll shortly break for lunch and have the breakout. So any burning questions?
All right, Dale, that's a good question. And I think part of it is you should separate yourself from that question to begin. Because your job is to be passionate about what you're passionate about and come up with a question that you're interested in. It's your mentors and your mentor group, their responsibility for really marrying this idea of what you need. And it's not just money, it's resources with the feasibility. Now, if you're asking about, well, should I be thinking about applying for a junior grant or a K grant, like early stage investigator award, or, CHOA has mechanisms like the Warshaw Award that, critical care, because of Jocelyn, has really been benefited by to get. It really depends on what your project's all about, And I think the biggest benefit downstream of making yourself do that is writing scientifically, because writing scientifically is really weird. It's really weird, and it's really different, and it's really robotic, and it takes time and practice and a lot of tolerance of failure.
I'll add to say, I remember the auditorium I was sitting in when I was starting my fellowship in adolescent medicine. It wasn't here, but I really remember somebody getting up and talking about K grants and R grants and all of these things that may be in your question. I don't know, I'd love to talk to you after. And thinking like, why should I care about any of that? I just want to be a good adolescent medicine doctor. And I think I would agree with you that your stage now is to find your passion, find your question, and find a team that will support you, including the funding and resources to do it. But then I also remember my division chief telling me I needed to apply to the equivalent of what I think the Warshaw grant would be. So like a grant for residents and fellows for a very small amount of money, like $3,000. But I didn't even need to do the project. It was an education project. I ended up using it to pay the residents, basically get them breakfast so they would participate in my educational intervention and some other things. And I was like, I don't even need this money. And she's like, yeah, but you need, what you're doing in fellowship is learning to ask for what you need so you can keep this work going. And so I'm sure they also appreciated not having to buy the residents breakfast, but it was my first chance writing a very small pilot grant and putting together a budget. And then now that I've gone on to do that many, many more times, I appreciate being pushed to do it, even though they probably didn't need me to get that money.
All right, well, we will continue our conversations now over lunch. And